Deb Mosier in Kentucky and things like that are widely published and have developed the theoretical concepts, that they've identified as problematic in heart failure as far as self-management and self-maintenance of heart failure. So I kind of took Barbara Riegel's theory, but I also, because it didn't have any of the contextual and emotional pieces on it, I used Leventhal's model of, it's a common sense model of how lay people, not healthcare workers or providers, but how lay people tend to process and interpret health and illness. And so with that, I merged the two models and moved forward in developing our questionnaire, which was then tested and went through quite a rigorous validity and reliability testing. And then we applied for a grant with the National Institutes of Health, the National Institute of Nursing Research, and I was awarded a 5-year grant. And so I wanted to share with you the original article. I hope you all got to at least receive the article, whether you got to read it or not, because a lot of what I'm presenting today comes out of that published article. But this is about the patient's perceptions rather than the healthcare provider perceptions of how they perceive their worsening heart failure symptoms. And so this is highly exploratory, because not very many people were doing this at the time. And I need to move to the next slide, please. It didn't move for me. Okay, great, thank you. So a little bit about background. Annually in the US, these numbers have not changed too much over the last couple years, but we have about 1 million heart failure hospitalizations per year. We have that attributing to over 6.5 million hospital days, inpatient days, and over 11 million physician outpatient visits, totaling over $40 billion. We do know that hospitalizations that are unplanned occur disproportionately in the heart failure population compared to any other population in healthcare. About 1 in 4 persons are readmitted within 30 days of hospital discharge, and we are improving somewhat on this 30-day readmission, but we're only extending it out to 60 to 90 days, according to the literature. We're not making big headway, it's simply incremental. And we do know that hospitalizations are an independent risk factor for death in patients with heart failure, simply because when they go into the hospital, typically it isn't like you go in and have a gallbladder surgery or an appendectomy and that's curative. So you come out and you're feeling better and you recover from the surgery and you move forward. That doesn't happen in heart failure. Typically a hospitalization, for whatever reason, in a patient with heart failure, they go down below their baseline and they never truly come back up to where they were before they had symptoms or the illness that led to that hospitalization. And we're finding that whether it's a heart failure hospitalization or a hospitalization in persons with heart failure for other reasons, so that all-cause hospitalization. So we do know that people who self-manage their heart failure, and that is the majority of people with heart failure, they live in their homes, in their own communities. Many of them are younger and younger over the years that we're seeing. This is not simply an elder care condition anymore. We're seeing it in people as young as 18 years old through their 20s and 30s, and for a variety of reasons, not simply ischemic heart failure. So symptom management issues that we see are inconsistent heart failure self-care research findings. The literature is just all over the board. You can read one article and then you read the next article and it demonstrates just the opposite findings of the previous article. We have a wide range of symptoms in heart failure. We have a wide range of symptom perceptions among patients in heart failure and their attributions, what they believe is the cause or the root cause of their symptoms. So how they attribute their symptoms is very important as to how then they will self-manage their symptoms. So the wide range of symptoms, perceptions, and attributions are attributed to treatment side effects, other conditions patients have, such as lung disease, diabetes, even arthritis or gout, overlapping and unresolved symptoms from another condition, such as we've had people who were in the hospital with a pneumonia and then they come back home, they're discharged, and they continue to have overlapping or unresolved symptoms, and it isn't the pneumonia, it is their heart failure, and then they're back in the hospital with heart failure. Aging processes, a lot of people in our studies are attributing their symptoms to just aging processes, especially among the elderly. Symptoms that wax and wane over time. So I thought my symptoms would stop because they got better, but then here they come back again and they're even worse. But those that wax and wane over time are less likely to be reported early than those that come on fiercely, so to say. Low somatic awareness, we see this a lot more in men than women, and we see it a lot, of course, with people with advanced diabetes and kidney disease. Variation in symptom responses. So how people respond to their symptoms, again, gets back to the attribution and self-treatment. And do I call the doctor's office? Do I not? Do I call my case manager or whoever it is? And a lot of times it is not the healthcare provider. It's someone in their social network. So the purpose of the study that we did was to explore symptom perceptions and self-care behaviors leading up to hospitalization for acute decompensated heart failure. So all of these patients in our study were interviewed during their hospitalization for heart failure. We talked to them a little bit about other types of hospitalizations they've had, but all of these people were admitted for heart failure, acute heart failure. It was a cross-sectional design, meaning that we interviewed them one time and there was no follow-up to the interviews. Anything that we needed to ask in terms of clarification of the questions we asked, or that we repeated the answer to them if it was a narrative, open-ended response, we would clarify that right then and there. And all of these were recorded and transcribed verbatim. So we had 60 patients in a Midwestern teaching university hospital that were admitted for acute decompensated heart failure. We did the semi-structured interviews, and again, this interview questionnaire went through rigorous testing and was based on the day reconstruction method first proposed by Kahneman and colleagues. And this Kahneman has done a lot of work and is an economist by nature, but did a lot of work in the 1940s and 50s with the government, was petitioned by the government to do mass interviews with people across the US because the government wanted to know what people were doing with their leisure time. So he tested a survey method, and all of his colleagues, and they went out to people. Of course, we couldn't do it online back then, but it was like true population health, where we had to go out in the bush and interview people one-on-one in person. And they had people reconstruct their days and what they did from the time they got up until the time they went to bed, including how many hours of sleep they got, and then what they did on their weekends or their leisure downtime. And so a lot of this fed into parks and recreation and what they did for exercise, what they did to maintain their health and things like that. But it also was a scientific method that the way the questions were asked that enhanced recall, because we attached it to a certain time of day or a usual activity or routine during the day that if patients couldn't remember, they would think of, oh yeah, when I eat breakfast or when I'm getting ready for work or whatever, oh yeah, now I remember. So we were getting that as well, which I think enhanced the accuracy of the recall of what they were doing that day. Because once they get into the acute decompensated heart failure mode and things really start rolling through an ambulance ride or an emergency room visit or even the ICU or telemetry stay, we find that time gets lost. It isn't a mental status or a cognitive change so much as it is the confusion of all the hubbub or the activities of the formal healthcare system. So we'll go on to the next slide then and won't belinger those methods anymore. We had several sections of the interview questionnaire. And I know this looks long, but it really was not very long, not a very long questionnaire. But we had sections on the symptoms patients experienced, what their interpretation and attributions of those symptoms were, what they did to try to relieve their symptoms, and this is all before they contacted anyone or entered the formal healthcare system. And then if they talked to someone else about their symptoms. And we call these people lay consultations, lay consultants, rather than caregivers. Actually, some of our patients have been insulted by us saying the term caregiver, and some of the caregivers or spouses or adult children or whatever have been insulted as well as being called caregivers. And I know that a lot of this comes out of the oncology literature and that we've dubbed or stereotyped this name, such as patients, caregivers, healthcare providers, things like that. But we called them lay consultants because if truly patients are able to do self-care and manage their own lives, then they do consult with other people, but it's not necessarily those people who care for them, so to say, or provide informal or lay level of care. And then we talked about the timing of when they reported symptoms to their healthcare providers. And that was very important to us because we wanted to get to that pre-hospital delay factor. And then we wanted to also know that, to our knowledge, no one else has done yet. We wanted to know if you reported your symptoms to your healthcare provider, how long did you have to wait before you got an answer back or a response back from those providers? In other words, if I'm a patient and I call the clinic, the doctor doesn't answer the phone. My nurse practitioner does not answer the phone. And so it's a receptionist. And so I end up saying this and that to a receptionist or into a reception recording nowadays that may get listened to during lunch and then immediately after the day of seeing patients is done, like between 4 and 5 p.m. maybe or later. And so what we wanted to get at was, so you reported these symptoms, how long did it take to get a response from the formal healthcare system or get an appointment with the formal healthcare system? Okay, we'll go to the next slide. So these are the demographics of the patients in our study. You can see that we had a good distribution of both men and women in the age groups of 20 to 25 and 56 to 89. We had almost a good split between white, black, and then multiracial, mostly was Hispanic and Native American. We do have, where I was, we did have quite a larger population, I think, than most states of Native American. Education was was very typical of other studies, as well as whether they lived alone or married or not married. And then we also looked at, we have the LAT group, the living alone together, which is an older group of folks that we have now that are together, but they still have their own living arrangements. They'll stay with each other, but they still have their own house or condo or apartment or whatever. So they're not together all the time. They're not legally married, but they're living alone together. I don't know how else to say it. It's an interesting group, and we find that in our aging or elderly population quite a bit post-retirement. Some of our folks did have children, dependent children at home. And then a fair amount, I think, were employed. Interestingly, most people did not feel that they had good income adequacy. The way we parsed that question was if they have money left over at the end of the pay period, or if they have just enough to meet their bills, their needs, or if they don't have enough to meet their needs. And of course, I don't think it's any surprise that medications take a big hit on their income. And then the health insurance was very typical of others, and most of the public or other was military and Medicare. Okay, so we'll go to the next slide. On average, patients experienced 3.77, or what we say is 4 symptoms before hospitalization. The big symptoms, the salient ones that we see in heart failure, were shortness of breath, swelling, and fatigue or edema. We just can't get away from that. And it is my thought that once we see any of those 3 salient symptoms, that they've already bought their ticket for a hospital stay. Symptoms did not vary significantly by how long people were in the hospital, how long they had lived with a heart failure diagnosis, or whether they had been hospitalized previously for acute decompensated heart failure. And that's really interesting, because one of the things that we found was that simply because you had a hospitalization experience or several experiences with hospitalization for heart failure over the years, it didn't build that experience. Symptoms were not the same from hospitalization to hospitalization. People would tell us, well, this didn't feel like the last time I was hospitalized for heart failure. So there's a lot of variation there. And as you can see, the symptoms experienced are quite variable. And we won't go into each one of those, but you can see the top ones there are still the shortness of breath, the swelling, and the fatigue. Okay, good. Symptom attributions. Interestingly, almost 2/3 of patients experienced early warning signs before they had the full-blown symptoms, but only 6 patients attributed those to their heart. We had multiple attributions to anything but their heart. 25 patients, or over 40%, attributed symptoms to changes in their diet. They went on vacation or they went out to eat and they weren't able to watch their diet, changes in medication, changes in their weight, sleeping pattern disturbances, and then exercise. And patients who had lived with heart failure for under 5 years were less likely to consider the changes to medications as a cause of symptoms as much as those who had the diagnosis for over 5 years. And I thought that was kind of interesting because the longer that patients have heart failure, the more medication changes they have. It seems like when they're first diagnosed and if they've had a hospitalization, we're in that medication adjustment period. And we're trying to titrate patients, especially it seems like with the beta blockers, that to get them on the doses of the guideline-based medications. And a lot of times people who have been in decompensated conditions such as acute heart failure and hospitalization, we can't up-titrate very quickly. They just don't seem to tolerate it very well. Okay, we can go to the next slide. So we asked patients what kind of things they did for symptom relief before they contacted their healthcare provider or entered the formal healthcare system. Almost half of the patients engaged in some type of self-care strategy to relieve their symptoms, and self-medication was the most common. That was problematic for us because not just the first one listed, the Lasix, because we see that self-titration there with Lasix quite a bit, but with the nitroglycerin, the prescription analgesics, especially the opioids, metformin, we were finding that people were taking multiple doses of metformin, which just baffled me. I really kind of scared me about that one because of the liver involvement, and aspirin, oxygen, and prescription breathing treatments, not just the inhalers, but the actual treatments, home treatments themselves. Less commonly, they would do things like raising the head of the bed, resting, walking, elevating their legs or feet, you know, on an ottoman, and then diet changes to relieve their symptoms. One of the things too that I don't know if anyone else has experienced this, and it was an isolated event, but it really made me scratch my head. In the Black population, I was receiving reports of medication sharing, and in the neighborhood, or people that they knew. Oh, your doctor told you you had high blood pressure. You know, I had a doctor that told me that one time, and they switched drugs, but here, I've got this. Why don't you take this home and try it and see how it works for you? So there was this sharing of prescription medications. And when I moved on to the St. Louis population over at Barnes Jewish and Washington University and collected more data on 30 more patients using this same format, I found the same thing in the African American population. And so I've been talking with some people about that because clinically, I think that this is beyond research. I think that this is an important issue that needs to probably be addressed. And I don't know if any of you have run into that or not. 43 or almost all of the lay consultant consultations were conducted face-to-face as symptoms occurred. So that tells me they were mostly with either spouses or partners or adult children. We can go on to the next slide. Okay. For attributions, people attributed their symptoms but then they told their lay consultant what they thought was causing their symptoms, but then their lay consultants gave attributions for what they thought was attributing their symptoms once people said, you know, described their symptoms to them. And interestingly, many of the patients, although they did not attribute their symptoms to their heart, most of the lay consultants did. And that was their first attribution, was their heart. And then, oh, it could be a respiratory disorder, or it could be, you know, problems with your diabetes. So they were in tune to their heart, whereas the patients themselves were not. But did that make a difference? So lay consultants gave patients advice on what to do about their symptoms, given their patients' descriptions of their symptom scenarios. But within that context, we had 15 lay consultants that gave advice but didn't offer any symptom attribution. So they really didn't know or didn't tell the patient what they thought was causing their symptoms, but they were very quick then to move forward and give advice. And most often, those lay consultants advise the patients to seek professional help for their symptoms. We had 30 patients who took the advice of lay consultants, with over 80% of the patients seeking care or attempting to seek care within one day, with 20% delaying for more than 2 to 5 days. So when we look at these delays in treatment seeking, and we know what happens in acute decompensated heart failure, to me that leads to that very small minority of patients using a lot, the majority of the healthcare dollars that we have for spending on heart failure. So this just gives you a breakdown of time-wise healthcare provider contact to emergency department. For 10 patients, it was 1 to 6 hours. For another 8 patients, it was 1 day to over 2 weeks. From the time the healthcare provider was contacted to the time the patient was seen in a clinic, if they were seen in a clinic, was 10 minutes. This patient said they virtually lived next door to the clinic, to 2 hours, 1 to 3 days, a week, and then up to 5 weeks for one patient. So some of this is due to callback and telephone conversations, and maybe patients not conveying how serious their symptoms are, or delays in getting an appointment. And then clinic to the emergency department. For people who did see a physician in the clinic and then went to the emergency department, one was within 20 minutes. They were sent from the clinic. Within 2 hours, we had 5 patients. Within 6 hours, 1 patient, and over 20 hours for 2 patients. And again, we did not get into how far away did you live from the clinic and the hospital and things like that. We do know that we had people who had to go home and, you know, make sure their children were taken care of before they went and things like that. So the take-home message that we got from this study was that patients tended to experience typical heart failure symptoms. Eventually, they had all or at least one of the top 3 symptoms: shortness of breath, fatigue, and edema. While nearly 2/3 of the patients had early warning signs before they had those 3 top salient symptoms, few attributed these signals to their heart, and efforts focused on thinking of their heart first are needed. And that's where we scratched our heads and came up with the Think of Your Heart First, or the TYHF acronym. Patients who had lived with heart failure longer might have undergone more prescriptive medication changes or self-adjustments than people who had not. And that was that 5-year cutoff that we did. We can go to the next slide, please. Nearly half of the patients engaged in self-care strategies to relieve symptoms before seeking professional treatment. So we need to delve deeper into that. We don't know much about what they're doing out there on their own, and how much of those prescription medication treatments they're doing, whether they're current treatments, whether they're old prescriptions that they've had, or whether they're someone else's prescriptions, a neighbor, an extended family member, so to say. And most lay consultants advise patients to seek professional care, even in the absence of symptom attribution, stressing the importance of, shall we say, lay consultant or caregiver involvement in heart failure self-care.
So, from here, Kay, I'd like to open it up to questions. And also thinking about, in what you've just shared, we have a number of care managers now in the state of Michigan, as we've had significant funding from our payers. And the question is, as care managers, where do we put our energies in working with heart failure patients. So I'm going to open it with that question. You're thinking, where should we spend our energy as care managers in making a positive impact on patients' health and well-being?
Well, I could give you some ideas. I would need to know where your current energies are being spent. I don't know where the majority of the energy on the behalf of case and care managers or coordinators is being spent in, whether it's on transitional care, whether it's on home care, whether it's on follow-up and, I don't know, social work, pharmacy, getting all those things coordinated. Where do you put the bulk of your energy in managing heart failure right now?
So I'll provide an answer, and if others want to pipe in, please do so. My guess is majority are discovering these post-hospitalization. Much of the focus has been on post-discharge calls, so subsequent to a hospitalization. And then in the clinics, we have the care managers that are working directly in primary care clinics. So it would be ongoing monitoring and follow-up, that especially if they're high-cost cases. If that helps.
So do the patients on the outpatient side, patients need to come in to the clinic to see the case manager in the clinic?
Yes, yes. So they're coming in the primary care setting. Much of the follow-up is telephonic, so they might have few in-person visits with the patient upon admission into care management services, and then follow-up and monitoring telephonically.
Okay. So a lot of the approach then is from the guideline-based or prescriptive side of it. It seems like, to make sure blood pressure's okay, medications are going well, things like that on the health side of it. Whereas a lot of what I do is in the patient's perspective, when they're no longer really our patients, once they're discharged from the hospital, they have their discharge instructions. They have a certain level of coordinated care beyond that. But once they go back into their home, each home looks different. Each community or neighborhood looks different. It isn't standardized like it is in the hospital. Patients do not self-manage in the formal healthcare system in the hospital. They are managed by others. We put their medications on a schedule that is convenient or standard for the hospital, not the patient. It may be totally different than what they do in their own home. How we store, dispense, and administer medications is totally different. The times and who takes the blood pressures and does the ambulation exercise or toileting or whatever the patient's needs are is all prescriptive and done on our timeline, not the patient's schedule. So when we go out into the home, it's quite variable. And that is the place and the context that's, to me, missing from a lot of our care and even care coordination. I can bring patients into the clinic and I will see them in the context of the clinic. And I coach quite a bit and I advise, I try not to tell too much. I do a lot of selling, so to say, but I try not to, shake my finger at them and tell them, like, oh, holy cow, what were you thinking or anything like that. But it's so different in the context of the clinic. I only see what they want me to see. I see that in our cardiologists too. The picture that's painted for the cardiologist is a little different than sometimes the intake nurse, who comes in and sees them and talks to them. And then all of a sudden they ask all the right questions. But then when the cardiologist comes in, I see a different story. And then they only will share with us what we want. And then when you get out into their community, into their home, then I'm scratching my head again. Well, the pharmacy is in the next town. I'm in Iowa, so we have a lot of rural farmers that live quite a ways and on gravel roads and things like that to get to the clinic, to get to the hospital, even to the pharmacy if they're not on mail order or something like that. But the home is its own booger, so to say, and people store, dispense to themselves, and engage in strategies differently in each home and community. It is not standardized in any way. And I think in part that's part of our boat missing, so to say. That's where we're missing the boat, is because that is beyond the purview of the formal healthcare system control. And then when they get in trouble out there, they land themselves in the hospital, so to say. So how to get at that piece of it for that very early detection in changes before people would come into the hospital is needed. And in our population, I don't know about yours, but in ours, people don't just live with heart failure. So early detection takes on a whole new meaning. I cannot ignore the kidney disease, the diabetes, the arthritis, the lung disease, COPD, emphysema, things like that. It's all interplayed. And so I always tell people, I don't care if your big toe hurts. I have a patient with severe gout. I said, I don't care if your big toe hurt. All paths lead to your heart. And so we were thinking, because people are not thinking of their heart first, and because they have so many comorbidities, we're trying to coach people and teach people and families to think of your heart first. If your big toe hurts, call me, because it will land you in the hospital for heart failure. And I don't know how else to put it to get to that early detection, but I would rather see them or get a call from them about that if they have any subtle changes, just subtle changes. And they can't quite name it. They can't quite put their finger on it, but they said they just didn't feel right for a few days before the shortness of breath set in and all the swelling and weight gain and things like that. So I don't know exactly how to back up that train, except for once it's left the station, the ticket's been paid for. So I tell them, any of those types of changes, think of your heart first. And so that's what we're moving toward. And I think too,
Great.
we have to get out into the community and the home more. And I'm not talking about home health care. I think we have to do more surveillance in the community and the home to help people get set up for self-care.
Yeah, I would support that. We do have a question, or maybe it's more of a comment, so I'd be interested in your thinking on this. That's, teaching to self-monitor using heart failure action plans, such things as daily weights, low sodium fluid. What is your thinking on that? Is that going to prevent readmission and admission? Helpful?
Oh, I think action plans are helpful. I think it depends on the patient and how they're implemented, what the expectation is. And in some instances, I've talked with different cardiologists, and I work with a variety of people in different cities and towns. Some people are getting away from low salt diets and not even worrying about that. Some people are getting away from the traditional 2-liter fluid limit, you know, where we used to ask people to set a Kool-Aid pitcher on the counter and, you know, for the day and not drink any more than what's in that pitcher of water or whatever, a fluid. We're getting away from that because I think in large part it just hasn't proven effective. And I think that's why we've focused more on the diuretic titrations and things like that, which are part of the action plans. I mean, people are titrating their Lasix or Bumex or other diuretics very well at home, depending on their symptoms and their weight, their daily weights and things like that.
So part of that, when we were in another health system observing, they had what they called the Self-Management Action Plan, which was an action plan for the patient around their medication. So as care managers, what I'm hearing you say, yes, important to work with the patient, but probably as important is to who is that person that they look to for advice, and empowering that person with the information as well. Is that accurate? Or
yes, yeah, it's kind of like in diabetes. We've heard people talk and come into the clinic and they say, well, you know, my husband has diabetes, so we just cook diabetes. I prepare meals for the whole family, not just for him, you know. So I think in heart failure, the same principle probably applies.
yeah.
And I think it's very important for a spouse or an adult child or the LAT person, whoever the partner, whoever they're with, to have the same information as the patient.
Great. So I've done a lot of the asking. I'm going to open it up to folks on either on their computer or on their phones. Any questions you have for Kay or thoughts? And if you're not comfortable asking it directly, you can put it in the chat as well. I can address it through the chat.
Good afternoon, Ms. Reader. Thank you for the information.
Uh-huh.
I am from a home health agency, unlike many of you guys, I think, are from Case Manager. So what we do is a home health care.
Uh-huh.
And our biggest challenge is to keep the heart failures out of the hospital. Like, if you had to, like, with all your experience, what are the top 2 processes that you put in place that you think that can help effectively keep our patients out of the hospital? What 2 things that come to your mind as, like, that you can tell all my clinicians?
For home health care nursing?
Right.
Do you have the action plans?
Yes, so we
patients?
do have weight logs and things like, the diet. We do talk about the diet on, like, from beginning, front load the visits. And we have the zone tools to explain to the patient what signs and symptoms that you need to watch out for. So the training is done, but I'm just like pulling up, since you are on one of the experts, I just want to know what do you think is the most important factor that can effectively help us bring the numbers down for rehospitalizations?
I think that we have to get to those subtle changes. You know, they get up one morning, they just don't quite feel the same. That's when you need to hear from them. We need to hear from them when they experience the subtle changes. Once they have the overt weight gain, edema, shortness of breath, and fatigue, although fatigue is kind of vague sometimes, because it waxes and wanes a lot. Every day is different in heart failure. But those salient symptoms, signs and symptoms, once they have those, it's too late. Whatever has occurred within the body that we do not see, covertly going on in there, has now overtly come out, and we bought the ticket for hospitalization. It's very difficult to turn that around, especially the older patients get, and the more severe the heart failure, because the gut gets boggy. It gets waterlogged, and even that extra dose or half dose of Lasix or diuretic is not going to make a difference because it cannot cross the fluid between the medication, the food, and the gut, the cilia, because there's too much fluid in between. It can't get and go where it needs to go. So they have no choice but to come in and get intravenous diuretic therapy. So we have to back that train up and try to talk to people about those subtle changes. How just feeling kind of punk today, kind of puny today. I need to hear from you on that day. You get up, you're not feeling okay within the first couple of hours. We need to hear from these people. And nursing detection is huge in this. If your nurses are out in the home, to detect some of this and ask some of the right questions is crucial.
Right. So historically, we are always looking for those big changes, and it's already too late when we are finding if those changes are. So we probably need to change the set of questionnaires for our nurses to ask, for the little smaller changes that, and explain to the patient that those are the symptoms that you need to report us for.
Mm-hmm. Yes. And they may be very vague. They may not be able to put words to it and point to, so to say, where the pain is. You see what I mean? But they will be able to tell you they just don't feel right. Something's just not quite right. They feel punk or they feel puny that day. They just can't seem to find their get up and go, so to say. But there's just something subtly different about their day, and that's what we're hearing from people, but they didn't know what it was until they had those full-blown overt symptoms that they could point to and say, oh, my feet were so swollen or my ankles were so swollen. They could see it and feel it then. They knew they were short of breath then, but once that occurred, it was too late to keep them out of the hospital.
We've turned around and we have started talking to the nurses that teach about the multi-factors, not just one. In the past, it was always, as you mentioned, low sodium diet, the weight gain, and we would focus, and this is what our patients or families would retain. But we were telling that it's a multi-factor, and you are so right. It's just a very subtle change. Thank you. I think it's excellent.
I would expect you to be the first to see that. And why? And I'm kind of envious here because you're out there in the home, and that's where I love to be. I love just not seeing people come into the clinic, but then I want to get in their car with them and go home with them too. And that was Dorothy Bruton and Mary Naylor's initial work, if you remember, back in the late 80s and early 90s. And a lot of that made a difference. And I don't know what happened, but we've had some of that just fall off the cliff, so to say. And I think we need to kind of get back to that a little bit. But in home health care, you're out there, you're in the home, you're in the community, you're doing all of that surveillance. You're in a prime position to really sense and see what's going on with these folks.
You know how our patients prepare to go to see you in the clinic. There's a lipstick on, the hair is done. You cannot detect a thing.
Yes, yes.
Okay, I've got another question through the chat. So, the question is, what would the treatment or action plan be if they did identify the subtle changes? So we want them to report them, but then what should we expect, or what should we think about implementing?
If they do have home health and there is a visit, allowable visit, I know we're really strapped when it comes to home health and reimbursement as well. Then I think that's where it starts. Otherwise, I think we need to get them in to the outpatient setting, to the clinic, very rapidly. Same day. I don't think we can afford to have patients waiting for availability appointments. And a lot of our cardiologists, I've got 2 here in Mason City out of a group of 10 that are very popular. And they're 6 months behind in seeing follow-ups. So to work in a patient who's experiencing these subtle changes, or when the home health nurse calls and said, it's really subtle, we can't quite put our hand on it, they're feeling this way or that way, I think they need to be seen. And then the clinic say, well, so-and-so's got this, we're booked behind, we're full for the day, and things like that. I am very good at not taking that as an answer. I am very good in getting people where they need to go. I can get very pushy at times, very assertive, and I just really think if we aren't going to do that, and that's what nurses do best, then patients will suffer. That patient will go on and have more severe symptoms. Oh, they can't see you for 2 or 3 days, so here's your appointment, get in then. And the appointment ends up being canceled because then the patient is in the hospital.
Yeah, so along with that is, so given what you just described, and then think about the place of entry is primary care. So many of these folks are managed by primary care. The primary care's one, availability. So that's one question. Do they have urgent, emergent available for these types of symptoms? But then as a care manager, going to the physician, what is the treatment plan? What is the guidance? The symptoms are vague. What are we actually going to respond with to vague symptoms that do not say they've got full-blown, episode that needs to be attended to?
Oftentimes when we have people call in and they have those early subtle changes without, full-blown congestion and all of that goes with it, the edema and everything, we can advise them to take an extra or half dose extra of their diuretic. We do try to get them into the clinic, and we do labs. That's one of the things the early detection we'll look at, is getting their labs that are more sensitive than externally our visual or auscultation or things like that.
And what labs would the care manager look at? What would be something to recommend, and with those labs to report back to the physician about?
We look at chemistry profiles, namely. We do look at blood counts because we're seeing so much anemia in heart failure, and we're seeing very poor nutrition, almost a malnutrition type of scenario in many patients. And there's a whole body of literature that seems to be hitting weekly, hot off the press, about increased mortality with malnutrition and heart failure. And so we look at, their albumin and things like that, but we have to look at that in context, not just alone, but because of the protein base and the shifts that we see. We have to look at that in conjunction, let's say, with BMIs, not just one result on its own. We do look at the BNP. And we do look at the external factors. We take their blood pressure. We look at their weight. We look for any changes between this time and the last time we've seen them.
And keep in mind, some of the folks that are on the line, it might have been some time since they've managed heart failure. So, thinking about, in particular, and looking at the chem profile, the blood count, what would be a yikes? And understanding that it's varied depending on what the patient's norm is. So somewhat you got to look at trending. But what would be some lab values that would be, here's what the action would be based on? Any insight on that, Kay?
Well, I think anytime you see a shift in electrolytes, either hypo or hypernatremia, low or high sodium, people with heart failure can get into those delusional states you know, where they have low sodium, or if they um, are eating or drinking, you know, with a lot of sodium-based products, you know, can alter that over time. Potassium, again, because of the diuretic therapy, things like that. The chloride, again, goes along with the sodium. We look at their magnesium levels, we look at BMPs, we look at their H&H, you know, again, for the anemia and the volume, intravascular volume, and just things like that. You know, they come in if they're any indication of their breathing isn't the same, or whatever, you know, they may have a chest x-ray, things like that.
Great. And I did share your intake form with the group. So, you know, I did review this with our primary care doctor, Dr. Beatty. He unfortunately couldn't be on the call today, but I did, you know, share this with him. And he said, you know, Sue, when I'm thinking about managing a heart failure patient, I'm always thinking about the treat to target. What is the goal for this individual with their heart failure? And he said, I often think about the staging with that and what's realistic for this patient's function. What do we want to realistically maintain and get to in managing the heart failure? So what are your thoughts on that?
Well, I think that that is a prime point and a prime concern. If you have a newly diagnosed and you have, you know, stage B versus a late advanced, you know, stage D, C or D heart failure patient with New York classification, but, you know, 3 or 4 versus a 2, then the treatment or the goals may be different. Anytime we have a diagnosis of heart failure, once you know, we've seen people just in literal shock in the clinic when they're seeing our advanced heart failure specialist, and they either don't hear, or it takes time to process the diagnosis and things like that. So on that initial visit, I don't think is the time to begin to discuss it, but within that context of the next few visits and even during early care, it's time to be talking about the advanced directives and you know, plan of care for the first year, 5 years down the road, if they live that long, and depending on how severe it is and things like that. So I think a lot of that comes as you develop the rapport with patients and families, and can open that line of discussion to look at where patients want to be, what their goals are, as well as what we can feasibly do for them in terms of heart failure. I don't see heart failure, you know, as the terminal disease that it used to be years back, before we had some of the medications and treatments that we do now, both devices and one of our newer medications called Entresto. But not everybody qualifies for these things, and certainly very few people can afford them, especially with the drug Entresto. So there's a lot of work to be done there, but I think the primary target is people who might still be working, to where they can hold their job, get to and from work, earn a living, support their family. The goals are going to be completely different than for the 85-year-old female who's got heart failure with long-standing hypertension and preserved ejection fraction and so on and so on, and may have some diabetes and mobility issues, and is widowed, you know, has outlived her husband and things like that. The goals are going to be different. But the treatment, of course, should be for the target. What is it that we hope to accomplish here?
Great. And I do have another question. It's about telehealth, really. It's saying, any thoughts on the video doctor visits that are offered through most health plans? And our health systems also are now offering telehealth. When the member has some of the more vague symptoms, is there any opportunity for the patient to use a video visit to share with the provider something vague to determine whether the symptoms can be triaged over the video visit versus having to try to get squeezed in for an appointment or an ED visit. What are your thoughts on the telehealth with heart failure?
Well, I think we've come a long way, and I think if they've got a good system, a good visual system for assessments, then I think that that's fine. You're going to take, if it's a physician, if it's a cardiologist, you're going to take the same amount of time on a telehealth visit that you do on an in-person visit. And so I think that's something to keep in mind, that telehealth hasn't to date really proven itself as an alternative to in-person visits, as an equal alternative. I think it is there. I think it serves a purpose for certain needs and geographic locations and things like that. But where I think we really need to expand it is in nursing. I think advanced practice nursing in telehealth visits could do a lot in keeping people out of the hospital.
Yeah, and that's part of the care managers, and case managers really, is the secret sauce is in the follow-up and monitoring. So when we have heart failure, especially when they're in those latter stages, the frequency of those follow-up and monitoring probably are much more important than what we would have with some of the other conditions, just because of the frailty. And, any guidance, if a person's in a, depends on which one you use, A, B, C, D, or 1, 2, 3, 4, the latter stages. What do you think about guidance on how often the care manager should be, at minimum, following up with that clientele?
Well, I think it depends. I think it depends on each patient. I don't know if they're living independently and they are doing well in their self-management. I think you can gauge that with that. But if they're noticing, if care managers or case managers are noting issues and problems, then I think you have to increase the dose of your interventions of care management, the intensity or the dose and the frequency.
Yeah, so when we were when we observed the health system on the East Coast, they really used the weight as the guiding factor. So if the patient had, I think it was a weight gain of 2 to 3 pounds, that was a follow-up immediately, and then pretty much so weekly for a short period. Is that, I don't know what you're thinking on that. Yeah,
the rule of thumb is 2 pounds within 24 hours, or 3 to 5 pounds within 48 hours. I think that earlier is better. If you see a 1 to 2 pound weight change, on the daily weight change, you need to be calling someone. Patients should be calling someone, and we can try to alter, do the extra doses of the diuretic or whatever. And if that doesn't work within X number of hours, then you've got to go to plan B, because the congestion is the piece of it that can snowball on people and kind of get out of control. And then there's no choice but to be admitted to the hospital, whereas they can come in and get an IV outpatient dosing, or get a home visit for IV outpatient dosing and monitoring and taking care of it that way, which again is a lot cheaper than going into the hospital, and it's a lot less stressful on the patient themselves than a hospitalization. They're more apt to come back to their baseline of health than they are if they have to go into the hospital. We find that time and time again, that hospitalizations don't necessarily make people with heart failure better at discharge. And that isn't anything about hospitals or healthcare providers in hospitals. That's about the nature of heart failure, the condition.
Yeah.
You just can't bounce back from it.
Yeah. So you kind of get in that negative feedback loop. Once you start that path, it's really hard to
Exactly. It
reverse
just
it.
snowballs. I
So
see
really
that
the,
there's 4 chat questions. Are those that we've
Yep.
already addressed, or are they new?
yeah, yep, no, I think that, that was all of them. So we went through the teaching, the self-monitor, right through the action plan, and then the question about the telehealth. So I'm going to open it up again. Any other questions from those on the line? Now's your chance.
This is Robin Skur. I have a question. I'm curious to know, maybe by the people who are listening, how aggressive that physicians are with ordering IV hydration outside of the inpatient setting, either with home care or infusion center, and having, you know, kind of a proactive plan in place like that. Because I feel like with primary care, I think my experience has been that they go to the emergency room pretty quickly. So I don't know, maybe physicians are doing that more, or maybe heart failure physicians are doing that more. I'm just curious about that.
So folks on the line, what is your thinking in your clinics? You can either through the chat, are your docs willing to have them come in for an IV and, you know, infusion, get them, push a little IV Lasix? Are they willing to, if they're not in the clinic, because I think that is a true challenge, Robin, is do we have those resources in our primary care clinics? But certainly we have IV infusion clinics that we could refer to. So if they're not in the clinic, are the physicians willing to place an order for an IV infusion? So we'll put the question out.
This is
Anyone?
This is Justina. In our practice, we still see that there is resistance. It's pretty much that the primary care physicians are trying to manage with just oral diuretics. They are trying to be more aggressive, initially maybe just a dose of furosemide and then Bumex, but still orally, if it helps.
I think you can do that early on. But again, if it doesn't work, or if the gut is too congested to absorb and use those diuretics, oral diuretics, then we have to move to a different mode, and that's intravenous.
I agree.
And so it's what you're saying then is that you're not doing a lot of IV diuretics within the home situation?
That is correct. Yes, we are not.
Okay, so the patients then are required to go into an institution, to a clinic, or to an infusion center, or to the emergency or urgent care center.
That is
or
correct.
Inpatient. Yeah, I would think that that could be an area that could be worked on to affect change in nursing.
Yeah, so that's the self-management action plan, thinking first step, you know, vague symptoms, try the oral. Symptoms are not relieved, the next step would be consideration to referral to an infusion clinic. And, you know, some of the infusion clinics have physicians on site. So if the physicians were worried about that, would that be an opportunity? You'd have a physician there that could evaluate the patient. I don't know, Kay, is that something you see or have seen work?
Right, yeah, and we even have an infusion site that, you know, people don't have to go through the emergency department. It's how I relate it, the way the physical structure and everything kind of looks like. It's similar or parallel to like the outpatient surgery center, so to say, a surgery center, but it's an infusion center, but they're not admitted as an inpatient. But if they need to be, you know, the hospital is right there, you know, next door. So that can happen there. One of the things, depending on the IV diuretic, if it's an infusion, you know, it all depends on what the need is. If it's very simple and we're going to try this and it's a short-term thing, I could see it being done in the home. If it's, 6-8 hours worth of IV fluids and diuretic infusion, to have a home health visit lasting that long, because you have to stay there and be monitored, with the patient and things like that. The infusion clinic is probably the way to go. When you talk to me about primary care, that a lot of your care managers are in primary care settings, what is the level of physician? Are we talking about family practice physicians, or are we talking about internists, internal medicine physicians, as the primary care physician?
Both. It's a combination
Yeah.
of.
So you have family practice physicians managing people with heart failure?
Yeah, if they might be doing it jointly with the cardiologist or the clinic, but yeah, they're still managing their health. So we have strong patient-centered medical home initiatives here. So really looking at the medical home being the entry point and also connected to our specialists. So I did want to share with folks, because there were others that commented from the question that Robin had posed. So here were some of the answers. One was, we haven't done much with IV Lasix at IV infusion centers. We have done a fair amount with PRBCs, iron, magnesium, hydration, but not with heart failure patients. Another said, we'll send them to the ER room if oral diuretics fail. We will see and do chest x-ray and exam. Our PCPs would not have them come to for an infusion because of the need for monitoring and telemetry and immediate lab results. So those were a couple of the comments to the question. I don't know, Kay, any thoughts on those comments?
No, I think it depends on the system, and like you say, the medical home in which you work and what the structures are and processes are there in the context of care, what the standard of care is there. I think different areas do it differently. I know, we're in an era of medical homes and ACOs and things like that. I just don't, heart failure is so complex, and because people don't just have heart failure, I am not used to seeing family practice physicians manage heart failure. I typically see this, the primary care for people with heart failure, as being internal medicine as the entry point for that. And then, of course, people are followed by their cardiologist as well.
Yeah, so maybe the opportunity here, because the specialists do not have necessarily care managers that are doing the regular follow-up and monitoring. That's really probably going to be the care manager in the primary, the patient-centered medical home, although some of them might. But this is where there's great opportunity to establish relationship with our cardiologists, with our heart failure clinics, to really say, hey, I just spoke with Mrs. Smith. She's got very vague symptoms. Can you get her in and seen in the heart failure clinic today? So is that where you see some opportunity in there?
I do. I think that's part of that care management or care coordination. Mm-hmm.
And that's where you think of the heart first.
Oh, absolutely. Absolutely. Yeah, it applies to the patients and families, but it kind of also applies to us. When we get these complex cases like that, and we know that the booger is with the heart failure. If patients have their COPD or emphysema or their arthritis or their kidney disease or their COPD, emphysema, if those seem to be going along and managed well, I always think of the heart first. I always think of heart failure first, because they can get in so much trouble with heart failure and become extremely unstable, even if it is the emphysema or the COPD or a reaction to a medication, or they needed to have their gallbladder out. I can't tell you how many times I've seen a simple outpatient laparoscopic gallbladder surgery end up, a cholecystectomy, end up in a 4 to 5 day inpatient hospital stay because of the fluids that anesthesia gives during surgery. And it's just too much for our patients with heart failure.
Here's another comment came in. So the comment is, I found most cardiologists in town not easily accessible and slow to respond and or very hesitant to do telephonic management. And then the other was patient might have a cardiologist or that, especially you probably experienced this, Kay, because you're in a rural area. The cardiologist may be 50 plus miles away. So, what do we do there? So I think that's back to think of your heart first before we're in an urgent situation.
Mm-hmm. Yes. Yeah, because, well, I'm in Mason City, Iowa. It's a smaller city, about 30,000 people. We have a patient catchment of all the North Iowa area. We have a little bit over in South Dakota, and we have southern Minnesota. And a lot of our patients come to us who do not want to negotiate the big city of Minneapolis or Des Moines to the south, do not want to drive clear over to Iowa City, which is about 2.5 to 3 hours from here to go to the tertiary university hospital, and do not want to go up to Mayo Clinic, because if they do, they're going to be there for several days. I mean, it's just the nature of the tertiary types of care that these institutions have. And a lot of our patients are rural, they're agronomists, farmers, or a smaller town. They're in agriculture in one way or the other, and they don't want to negotiate the larger cities or the big healthcare systems. We are a regional referral system, and we have 10 cardiologists here for about a 350,000 person catchment area, and we run 13 outpatient outreach clinics. So our cardiologists are on the road quite a bit. We try to keep the interventionists home because they kind of live on the acute side in the cath lab. But for our general cardiologists and advanced heart failure specialists, they are conducting these outreach clinics, as well as every day we have clinics, open clinics with 2 to 3 cardiologists in the outpatient clinic here. In cardiology, what I'm being told, and not just here in Mason City, it's other cardiology groups that I've worked with or talked to or spoke with at national conferences and things like that. They typically are more resistant to telehealth. They feel that for their subspecialty, they really need to see people in person. And their nurse practitioners, though, however, that work in cardiology are more open to seeing patients via telehealth or something like that. So there might be an avenue there where the nurse practitioner working with the cardiologist could do the initial visit with the patient and then determine if they need to come in or whatnot. But to me, that might be an opportunity for case managers or care coordinators to not talk with the cardiologist first, but with the nurse practitioner. That might be an open door there for them, or a window to begin moving that direction. What do you think about that?
So I'm not sure, the care managers on the phone, if you started developing some rapport with some of the cardiology clinics And, you know, most of them do here have either PAs or NPs that they're working with. And I don't know, have folks tried that? Is it something to, maybe something to consider, is really thinking about this, especially with the, you know, later stage heart failure? Because you've got to have a quick access, is what I'm hearing.
Mm-hmm. Mm-hmm.
This is Robin. I'm also thinking that this is a great opportunity for us to think about who do we have in our systems, or who are we connected to, and what kind of programs do they have, and are our patients connected to those? And if they're not, are there stages, maybe stages in which the heart failure clinic manages the whole patient, but maybe patients not as severe that they can give some really good guidance to the provider, the internal medicine, so that they can be managed in some sorts of ways, you know, before they get that sick.
This is Shelley Bisfay, and I just want to add something that, and I don't know if this is doable with very many clinics or not, or how it works out, but I do have a good relationship with one of the cardiologists and the PA, because we have a patient who in particular has multiple different issues, one of them being CHF, and I have developed a relationship with her from the primary side. And what was happening was she was calling here and she was calling there and she was calling her this, that, and the other, and trying to get directions when she would have weight gain or get confused about her pills or if something changed. And so we basically centralized all conversations and issues to come into me. So she learned to call me, and then I reach out to the cardiologist or to Megan, who's the PA, and say, hey, this is what Joanna's reporting. What do you want to have happen? And, you know, if it's weight gain, because what I also realized was that she was having difficulty with urinating and she was retaining urine. So there was multiple issues, and then we had to get something going for that. But yeah, so very complex, but it is going much better with her having one person that she's bringing her concerns to, and then I reach out.
I think that's a fabulous way to do it. It really streamlines it, and then you know the purview of everything going on, not just bits and pieces of that patient's
exactly.
care. Mm-hmm. Mm-hmm.
Yeah, that's really the role of a care manager,
Right.
to act as that hub and be the kind of the traffic cop. So yeah, it's beautiful. That's great, Shelley. I've got one more comment here. It says, one takeaway I think is to find out what services might be available at a heart failure clinic. Do they do Lasix infusion? Also make linkages with cardiology, see how specialists are willing to provide next interventions PCP could do. So yeah, I think that's a great comment. Plan. Well, we are, oh, go ahead.
One other thing is, like, as a home care agent, and like now our nurses and our therapists, they do know about CHF, and they do tell the patients about it in a very detailed manner, and like they do try to use motivational interviewing and things like that to get. I think the most important factor is the patient engagement. Are the patient, like, how engaged are they in the process themselves, which comes down, it all boils down, because see, even though we are a home care, we are not there 24/7. Obviously, a doctor's office is not going to call them every day. Mm-hmm. So they're being informed, and some of these patients are having heart failure. They have been to the hospital 3 to 5 times before we even stepped in. So, like, we need to come up with improved strategies of patient engagement, where they kind of take the responsibility that we do have to monitor this on our own, because home care is not going to be there for more than 30, 40 days.
Mm-hmm. Right. We do need a patient activation and patient engagement and a plan for all of that. I did see a comment also come up while you were speaking about affordability of scales for daily weights and things like that. That is a real issue as well. And one of the things for the group up here in North Iowa, when I was consulted with for that group on, they wanted to get involved with research for their patients in this whole North Iowa community is when we set up the foundation funding source, one of the things that we did was we bought scales for patients and we distributed them through our foundation at the hospital for the heart center, so to say. But they were not expensive scales. They weren't like the digital Weight Watchers scales or anything like that. But we did get them at a discounted rate from, I think it was Target, one of the Target stores. We wrote to them and we got a batch, like a case or whatever, and we were able to distribute those to patients. I'm a real firm believer where there's a will, there's a way, and even used scales that are in working order, as long as they're calibrated or set to 0 for that patient, so to say, then that's the norm for the daily weight on that, and you can gauge differences there. But that's how we handled that for patients who could not afford a scale or did not have a scale.
Yeah, and I feel like at one point during one of the trainings, there was someone that said there was a company that would provide scales free of charge, but gosh, it's been such a long time. So I think it's absolutely something to look into. And, many of the large box stores do have some discounts or availability. So it's certainly worth checking into. And then there's the comment about the Priority Health will supply telehealth services for their patients. So I think that's also thinking about the monitoring. So, many of the home health care agencies have the telehealth or the scales in the home that they can step on and get an instant read.
Mm-hmm. Mm-hmm.
Yeah. Well, we are at the time. Kay, thank you so much for your presentation and really great conversations. And thank you, everyone, for joining in on the conversation. It was very helpful, I'm sure, to many. I know it was for me. I learned a lot and really appreciated it. So thank you, and thank you to everyone that attended.
Thank you. Thank you for inviting me.
Great. Thanks, everyone, and hopefully you'll join us next month. So, all right, thanks, Kay. I'm trying to find it.